see what slide is on, right?
I think so. When you stand on the podium and then there's a stool as well, if it is not, if it's blocking.
Good morning. If you could all please take your seats now, we're about ready to get started. So this is the first concurrent session, Recovery and Reimagining Childhood Essential Immunization. If you're expecting presentations on demand generation, you are in the right room. If you're not, we'll give you a minute to sort yourself out. So let me first welcome all of you to this session. I think there was a large focus on demand generation earlier this morning, and we have Sabin and UNICEF and Gavi to thank for that. And do thank them for putting the focus on demand generation today. My name is Sharon Barnhardt. I'm the Director of Research at the Center for Social and Behavior Change, which is a research and impact center out of Ashoka University in India. In addition to doing academic research and applied research, we also run behavioral insights units for the government there, one out of Niti Aayog at the center and in Uttar Pradesh and in Bihar as well. So I have the pleasure of welcoming 5 great researchers today to present very interesting and timely research on immunization. And so the immunization research today spans 3 continents, and 4 of the 5 presentations are about routine immunization. One has a focus on the emerging issue of the RTSS malaria vaccine as well. They're all targeting individuals for increasing demand, but especially targeting parents with a bit of a nuance, right? So not just parents, but parents as people who are working mothers, parents as people who work in labor-intensive industries or in the informal sector, or parents who mistrust the health system where they are. So while there's a commonality, there's also a bit of nuance in this as well. A couple of the papers also identify, train, and teach, develop influencers. Sometimes they're peer influencers, other times they're social influencers. And we have a lot of mixed methods and rich work here today. We have we have research with focus groups, interviews, surveys, systematic reviews, and an RCT. Some of the research is looking at understanding barriers and kind of diagnostics, and that's coming from Malawi and Indonesia. And there are a couple of efforts as well to involve the private sector and look for interventions and support from the private sector for childhood immunization. And then we also have research today that's looking at intervention-based research and studying what actually works in Nigeria, India, and the United States. So there's a lot going on today and a lot that we have to learn and be excited about. The organization of this session is that we have 5 presenters in order. One of them will be remote. But she'll be here for Q&A, we hope. But we'll finish all of the presentations and then open it up for Q&A at the end when the microphones can be passed around. Okay? So I think without further ado, we should get started. So our first presenter today is Dr. Mofeyisara Omobowale. And so Dr. Omobowale holds a PhD in anthropology from the Department of Archaeology and Anthropology in the University of Ibadan in Nigeria. She was a University of Ibadan postgraduate school scholar, a recipient of the American Council of Learned Societies African Humanities Program Doctoral Fellowship, a Cadbury Fellowship, and an ACLS AHP Postdoctoral Fellowship. She's an alumna of the Brown International Advanced Research Institute and a Carnegie Fellow. Her interests lie in medical cultural anthropology, public health anthropology, maternal, child, and adolescent studies, and medical history. Dr. Omobowale is currently a senior research fellow and lecturer at the Social and Behavioral Health Unit of the Institute of Child Health, the College of Medicine, and the University of Ibadan in Nigeria. Her work today focuses on working mothers using mobile clinics and social influencers. Welcome to the stage, Dr. Omobowale.
Good morning, everyone. Thank you, Sharon, and I'm happy to be here. I'll be presenting part of our study today, and it's titled Increasing Demand for Vaccination Through Innovative Child Immunization Strategy for Working Mothers in Ibadan. And I want to be focusing on the role of social relations influencers. This is my outline. I'll run briefly through the introduction, the project description, the method, results, lesson learned, and the conclusion. In Nigeria, it is believed, we all know in Nigeria, that high vaccination coverage increases the chance of children to survive because it helps to reduce child morbidity and mortality. But however, in Nigeria, the coverage, the demand for childhood immunization is still very low. And looking at the NDHS report of 2018, which is the latest that we have, one can see that the immunization coverage is actually very low. The percentage of children that has received all basic vaccination as of 2018 were just 31. And looking at Oyo State, where the study was carried out, Oyo State, Ibadan is the capital of Oyo State, about only 23% of children have received basic vaccination, while 70% received age-appropriate vaccination. And this is quite low, looking at the percentages. And in addition to NDHS report, the MISC and the NISC review showed the same way that in Oyo State, 21% of the children had only basic antigens, while 14% took all 1 year antigens, and about 42 had no vaccines at all. This is, of course, is not encouraging, and it shows that there is considerable gap in the ability to fully vaccinate our children, and the demand among mothers is very low, especially working mothers. So, yes, the study focused on working mothers in the informal sector. Looking at the pictures from the study, you can see different categories of working mothers in the informal sectors that we captured from the study. And why informal sectors? Looking at Nigeria, Nigeria is a country where the informal sector thrives very well. And 70% of those who are working on the informal sectors are mothers. We have different categories of mothers, and one of the spaces where we can refer to as informal sectors in Nigeria is the market space. And the picture, though not mine, depicts a mother taking care of, this is a child of less than 6 months, but that's the best place she can put the child at that time. And this further stresses the fact that immunization is not negotiable. And the demand has to be increased, that something must be done. And that was why we focused on working mothers, those who were in the market. The market space in Nigeria, especially in Ibadan, it's a space where you find different categories of mothers. The mother, nursing mother, grandmothers, grandfathers, and different categories. And one of the things that is very important to note about this set of working mothers is that they leave home as early, some of them as early as 6:30 a.m., and they will not come back until 7 p.m., some 9 p.m. And some of the interventions that has been done, even on the community basis, they are missed out from these interventions. And we should also understand that these categories of women, of mothers, many of them are geared towards making profit. Their livelihood depends on what they make daily. So it is a lot difficult for some of them, or many of them, to go to traditional immunization center and spend 6-7 hours in order to immunize the child. Once they go once or twice, there are other demands. They don't want to lose their profit, they don't want to lose their customers, so they will not go back, and they find it difficult to actually complete or to demand for more immunization for their children. And the study is an exploratory cross-sectional study carried out in Oyo State, Ibadan, and we selected 3 markets. Oje, Bere, and Bodija market. These markets in Ibadan are significant. Oje is a traditional market that has been in existence for more than 100 years. Bere is also a traditional market located within the urban slum of Ibadan, and it has been in existence for more than 6 decades. And then the market, the Bodija market, is also a market, the largest foodstuff market in Oyo State, and probably in West Africa, that consists a lot of working mothers. Our solution, the solution we took to the market were two, but one of it was mobile clinic service. We took mobile childhood vaccination clinic service close to the mother in the market. And while we were actually planning to do the intervention, we had a baseline study. And our baseline study revealed that rumor, misconception about vaccine, female gender subjugations are as part of the barriers that have actually prevented mothers from uptaking or demanding for vaccination for their children. So we had to look into this, and we came about working with VAC social relations influencers. And the vaccine social influencers in the market are just typical opinion leaders, individuals of influence whose ideas and convictions have influenced over targeted group. And this group of people, like I showed in the pictures, were between the age of 35 and 82 years old. And we didn't just go to the market to select them. We selected them based on certain criteria. And one of the criteria that was important to us was that these people were people who had a good layman knowledge about working of the basic vaccines, childhood vaccines, and they have at one time in their life or the other uptake vaccine for their children, their grandchildren, or even for themselves. So we selected them based on this. And one of the things why we had to go through them was they had health-related social support that they could activate to help bring mobile immunization health services closer to working mothers in the market. And let me cite an example. One of the reasons why these people were needed, because some of the mothers were willing to uptake the vaccine for their children, even though the child, maybe 3 years old, 4 years old, had never had any vaccine. But for instance, one of the clients told us, oh, I love to take this vaccine, but in my husband's family, it is a taboo to use needle on their body. And my husband must not see me with the vaccine card. Then this particular woman, one of the woman in the middle, she was one of our influencers, and I had permission to use her picture for presentation. And she stepped in, spoke with the husband, offered to keep the vaccine card for the woman, and we were able to vaccinate the child and completely. And this was one of the reasons why we engaged them. Okay, then the results. Our solution was tested in those 3 markets on 156 children of working mothers in those selected markets. And then the dropout population that we reached in those 3 markets were 54%. And then the intervention also reached 46% zero-dose children. And how did we get those population? We got many of them through the VAC influencers, because they spoke to those working mothers in the language that they understand, in the contextual language. And the lesson we have actually learned from this is that the role of social influencers is very important in increasing demand for vaccine among working mothers in the study population. And part of their roles were that they guided mothers in tuning to the interacting with us on the intervention. And Another thing they did for us was that they changed the community health seeking management behavior to participatory approach, because they were actually involved in the mobile clinic services. They were always there. They were the one that would say, oh, I know you have never taken any vaccine for your child. Come, these people can be trusted. Then another thing they did for us was to address contextually the issue of myth, misconception, misinformation, and about vaccine, and then they were able to address the issue of gender subjugation, especially when the mother cannot take decision to uptake vaccine for their children. They had to talk to the father, and because they are well respected and they know how to talk to them, they know how to get to them, they actually came forward. Then the vaccine influencer promoted a more pro-vaccine narratives for us, and they were able to also change the social norms through personal experience at the participatory child immunization approach. And they have, like, for instance, one of the, this woman, not because there was really any barrier for her to uptake vaccine, but she just doesn't like needles. And even while she was encouraged to bring her child for the vaccination, I'm not sure if you could see her reaction to the vaccine. And they were able to share their own personal experiences with the working mothers. For instance, one of the vaccine influencers told them about how a child who had a scholarship to study abroad got scholarship, and she had to look for the vaccine card and some other things, which also make a lot of meaning to them. And yes, then we discovered that 30% of mothers who attended our clinic were actually brought by the vaccine influencers. And the social support is important in child immunization and health promotion. And we also know that the vaccine influencers will impact, the story positively. And these are my references. And I want to thank everyone here, the Big A Foundation that sponsored our study, the University of Ibadan, my home, and Gavi, Vaccine, Sabine, and UNICEF, and my group, Shivax. Thank you.
Great. Thank you for that, Dr. Omobowale. Our next presenter couldn't be here with us today, so I'll introduce her while they're getting she has a recorded presentation for us set up, and she might be able to join us for Q&A at the end. Dumisile Nkosi is a registered medical doctor from Malawi who trained with the University of Malawi College of Medicine and a vaccinologist trained by the University of Siena. Currently, they work as a clinical trial coordinator at the Training and Research Unit of Excellence in Malawi, overseeing a clinical trial that focuses on post-discharge malaria chemoprevention in under 5 children admitted for severe anemia and severe malaria. They are passionate about clinical research, generating evidence to reduce the burden of infectious diseases in pregnant women and children in Malawi and across Africa. The study presenting today investigates the determinants of vaccine coverage in 6 to 23-month-olds and the acceptability of the RTSS malaria vaccine. So, without further ado, would you please play the video?
Hello, my name is Dumisile Nkosi. I'm from Malawi, working as a clinical trial coordinator for the Training and Research Unit of Excellence, and also an alumni of the University of Siena of the Master of Vaccinology and Drug Development. The title of my presentation is Determinants of Vaccine Coverage and Acceptability of Malaria RTSS Vaccine in Children aged 6 to 23 months in Malawi, a healthcare provider perspective. And this was part of my thesis project with the University of Siena. So I'll take you through these subheadings throughout this presentation. And globally, 44% of the world's unimmunized and incompletely immunized infants are in the African region. And the African region's coverage of the diphtheria, tetanus, and hepatitis 3 vaccines was at 76% compared to 86% of the global coverage in 2020. And there's also been an increased overall coverage of TBT3 from 84 to 94% between 2016 and 2020 in Malawi. And however, only 78% of the 28 districts in Malawi were able to achieve a coverage of more than 80% in 2020, which shows that there's still a gap of vaccination coverage in Malawi. Therefore, developing appropriate interventions for the success of the malaria vaccine program in young children needs an understanding of the immunization levels and factors affecting coverage. And the malaria RTSS vaccine was already implemented in Malawi as part of the pilot implementation program in Malawi, Ghana, and Kenya. And the theoretical frameworks on vaccine coverage that were used for this study was on vaccine coverage in low and middle income countries as described by Phillips in 2017, which encompasses intent to vaccinate by the caretaker, community access, and facility readiness. And theoretical framework on acceptability of healthcare interventions was also described by SECOM in 2022, which is a multifaceted construct that reflects the extent to which people delivering or receiving a healthcare intervention considered to be appropriate. So it has multiple constructs, which are summarized into prospective, concurrent, and retrospective. The main objective of this study was to evaluate the determinants of vaccine coverage and acceptability of the malaria vaccine in children aged 6 to 23 months in Malawi, and specifically to assess the determinants of vaccine coverage and acceptance in Malawi in general using a systematic review, and also to determine the perceptions of the healthcare workers on factors that will affect provision of the malaria vaccine in children between 6 to 23 months in Zomba, Malawi, and also to determine the healthcare workers' perception on the factors that will affect uptake and acceptability of the malaria vaccine, in addition to routine vaccines for children aged 6 to 23 months in Malawi. So we used a systematic review as well as a qualitative study. So the systematic review was used to answer the first objective, and we identified 1,237 articles, of which 12 were included in the analysis after searching, screening, and sampling. And the extracted findings were summarized in Microsoft Excel and were graded using the PRISMA framework and analyzed using thematic content analysis. For the qualitative study, 20 healthcare workers were interviewed telephonically at Zomba District Health Office in Malawi, and the recordings were transcribed into Microsoft Word and extracted into Microsoft Excel, and the thematic content analysis was done. So on the first objective, on vaccine coverage using the systematic review, it was found out that on health facility readiness to administer vaccines and favorable characteristics of immunization services and logistics negatively impacted vaccine coverage, as well as challenges in human resource allocation in Malawi and challenges with adherence to vaccine implementation protocols, as identified in some of the studies, which also negatively impacted vaccine coverage. And on community level access, healthcare utilization, those who did not utilize other healthcare services were less likely to get their children vaccinated. And those with a low socioeconomic status were also less likely to get their children vaccinated. And other child characteristics, such as a high birth order, were also found out to be to negatively impact vaccine coverage, because older children, the youngest children, were less likely to get vaccinated compared to the firstborns. And intentions on the part of the mother and caretaker, other practices, religious and cultural, were related to low coverage, and mothers were less likely to get their children vaccinated. And also, if the caretakers did not have trust in the healthcare staff, they were less likely to also get their children vaccinated. While the qualitative study on vaccine coverage found that willingness of healthcare workers to vaccinate the children for malaria vaccine was high, and this will positively affect vaccine coverage, as well as availability of equipment and good record keeping and surveillance within Zomba district. This will also positively affect coverage. While lack of transportation for immunization outreach activities, this might negatively impact coverage for hard-to-reach areas where sometimes healthcare workers have to use their own resources and money to find their own transportation to go and do outreach activities. On community level access, there's also education of guardians or mothers. Those who are less educated are less likely to get their children vaccinated. And community knowledge of the vaccine. For the communities that are mostly aware of the vaccine, they're most likely to get their children vaccinated. And trust in the healthcare system also affects the mothers in bringing their children to get vaccinated. On perceived burden of disease, since malaria is the burden of malaria is high in Malawi, most parents are most likely to get their children vaccinated, as reported in this qualitative study. On the vaccine acceptability, health system related factors, there was conflicting or improperly scheduled medical services, especially in outreach activities where there's multiple services that are being offered, for example, antenatal care, under 5 clinic, and postnatal care. So this might affect mothers who also have to attend multiple health services at the same time, and they might most likely maybe miss out on vaccinating their children. And insufficient resources for immunization activities, as well as caretaker literacy levels and influence of the male gender on vaccination decisions, where health decisions are mostly made by fathers, but children are brought to the hospital by their mothers. So there's like a long chain of decision making in vaccinated children, and this might end up missing out other children to come and get vaccinated. On the qualitative study, the perceived effectiveness of the malaria vaccine by the healthcare workers, this will also impact how willing they would be to administer the vaccines if they understand it and are able to also explain to the community. And burden and intervention coherence. So since malaria is already under the routine API vaccines, the healthcare workers were most likely to easily administer to the community. And this will positively affect acceptance by the healthcare workers to administer the vaccine. And on the community side, perceived burden of malaria and effectiveness of the malaria vaccine, as well as intervention coherence. So all in all, vaccine coverage and acceptability of malaria vaccine will be high in Zomba, Malawi. And outreach clinics have helped to reach out to the masses. However, the activities still need to be sponsored, especially on transportation allocation, which might help to reach out to all the necessary areas, especially hard to reach areas, as well as prioritizing on in-person training of healthcare workers so that each and every healthcare worker is well equipped with knowledge to disseminate to the community, and this might improve the vaccine acceptance as well as coverage within Malawi. And we cannot also ignore the impact of COVID-19 vaccine introduction on new vaccine introduction in Malawi, which may affect acceptance of the malaria vaccine. So there's really need that the community should be well sensitized on how the malaria vaccine is going to work and what kind of vaccine it is, so that the community is more acceptant of the vaccine. And also involvement of clinicians and nurses on malaria vaccine provision in Malawi would be essential in since they already built trust with the community, since they're the ones who see the patients for other conditions, and the patients might be more likely to get vaccinated if other healthcare workers such as clinicians and nurses are involved, apart from the health surveillance assistants, which are most likely the cadre that provides vaccination. And there's also need for empowerment of women by educating them, as well as involving the male population in maternal and child health services, which would improve vaccine acceptance and in turn also improve vaccine coverage. And there's also need for home-based economic development, which will also help in improving vaccine coverage in Malawi. So in conclusion, malaria vaccine coverage and acceptability of malaria vaccine would be high in Malawi. However, policymakers should address determinants of vaccine coverage and acceptability through health promotion efforts, increased resource allocation, and immunization service training for healthcare workers. The recommendations were already addressed within the discussion section, and I'd like to acknowledge the Director of Health and Social Services and staff of Zomba District Health Office in Malawi, and my supervisors and the coordination team at the University of Siena, as well as the TRUE team in Malawi. Thank you.
Great, thank you for that. I'd like to now introduce Septrina Frisca Tobing. Frisca has extensive experience in development, both in research and managing projects. Currently, she's one of the lead researchers at Empatika. She has also been involved in various mixed method studies across Indonesia and is skilled in employing qualitative and participatory research methods. Some of her recent work has focused on people's behavior related to COVID-19 vaccines and preventive measures, lead poisoning and pollution, and accessing malaria services. Frisca holds a master's degree in applied anthropology and participatory development from the Australian National University. Her research today will address parents' experiences of children's immunization in Indonesia, looking specifically for areas that the private sector can support. Frisca, welcome.
Hi, good morning, everyone. It's a pleasure to be here. So my name is Frisca, and today I'm going to talk about how we can engage private sector, and in the context of Indonesia, how their involvement can support children immunization. And I also want to acknowledge that this study is commissioned by UNICEF Indonesia and in collaboration with the Ministry of Health. And yeah, we've been very lucky to be involved in this study to understand better parents' experience and also how to better engage private sector. So I will start like why we engage private sector. So when we look at the complete routine immunization in Indonesia, the level has been stagnant. This is based on the most recent data. We see that the line at the top, so it shows that the immunization level has been stagnant, but then the unvaccinated and also the incomplete level has also a little bit like started to be increasing slightly. There are also like some literature talking about the vaccine confidence, just like what we talked this morning. There seems to be a decreasing trend of vaccine confidence in Indonesia. And then when we look at the further analysis of the data, when we break down the survey, the national survey data and see how the immunization uptake among working parents, we see that there is a lower uptake among parents who work in labor intensive, where there are also more informal workers. And we see that this is a place where the private sector can have strategic role, because in Indonesia, there are more than 80 million employees who work in manufacturing, retail, trade, and agriculture and plantation. And we see that if we can engage them, then this will be a very good opportunity to also support a better coverage of children immunization. So looking at that background, we are trying to do, what we did in the study is we want to understand, parents' experience when they take the children to immunization. So we do a survey, and this covers almost every province in Indonesia. We target those workers, the working parents who work in the labor-intensive sectors, and those who have children under 5. So we have more than 4,000 working parents, and in the questionnaire, we asked them about their experience when taking children to immunization. We asked about their perception about the immunization itself. And then, in addition to the survey, we also did a participatory FGD. This is something that we did in 10 provinces. We met with many women and also men, the fathers, because some of them are also involved in the immunization, although yeah, there are also like those who may not be as involved as the mothers. And then the working parents, this is like the opportunity where we actually like talk and also listen to their stories about how their experience when taking children for immunization. So one of our findings, main findings, is looking at the parents' experience of taking children to immunization. And overall, the journey or the experience can be captured in these 4 stages. So it starts with parents will receive information. So for example, they know about the schedule, they know the kind of vaccination that the children need to get at the time, and then they will try to manage schedule because these are working parents, and then they have to manage when, like the time or the day that they need to take their children, and then they will choose health providers. And usually parents will have their own preference for the health providers. It can be the community health centers, or it can be private clinics. Although, like when we talk with the parents, many of them, if not most, rely on the community health centers. And then the last stage will be the post-immunization. This will be the time when parents probably will need to take care of their children if there is any adverse events that are affecting their children. And some of the challenges that the parents experience, particularly related to the workplace here, related to the receiving information, is about there is a lack of information that is provided. So turn out that, say, when this immunization schedule is coming up, it's actually very helpful for parents. And then in terms of managing schedules, it talks about like the conflicting schedule between the immunization and also work hours. And then there is also no standard procedure to take time off, or when the daily workers face salary cut because they need to take time off or a day leave. And this is something that we're gonna talk more in a minute. And then in terms of choosing health providers, very few workplaces that we found when we talk to the parents provide immunization support. This means that, parents will need to find their own, especially those who work in more remote places. They need to find the health providers by themselves. And we also went to some places where people work at plantations, and this is particularly difficult for them. So for example, they need to travel for an hour, and the road is not always accessible for them throughout the year. And for post-immunization, we also see like the challenges related to when they need to take the time off. So this is something similar to the managing schedule. The managing schedule itself sometimes is difficult, but then after the immunization itself, some parents may need to take another time off to take care of their children. What I want to highlight here is about the challenges related to workplace policy, related to the managing schedule. So as I mentioned earlier, the immunization schedule clashes with work schedule. So many of the working parents will rely on the service provided by the community health centers, which usually happen during work days. And if there are some places where they can access the service over the weekend, but it's not as many, and also, or they can switch to service providers, but that means that they need to pay more. This is something that we also find in the survey. So there is worry about adverse events at the top, but the survey also shows that most of the working parents actually still take their children to immunization. And then like the second challenge will be the immunization schedule that clashes with working schedule. And then related to that is about the lack of standard procedures to take time off for immunization. So it is interesting that when we asked in the survey about the support provided by the company, almost half of them say that they can take time off or even leave for a day without salary cut. But it is important to note here that this is not a leave that is specific for immunization. So parents will take, and this is usually a more informal approach where parents will say that like they will come later or like they will just take a day off, but it is not specific for immunization. And then there is also a hesitance to ask for leave from the working parents because they worry that they will burden their coworkers. And I think like we also see like from the previous presentations that daily workers or the informal ones, they have more challenge in terms that they will face salary cuts if they take time off. And like all of these challenges related to managing schedules are mainly faced by women, unfortunately, because immunization is still considered a woman's job. But then, if it shouldn't be a cost like for women to take their children for immunization. Although like some parents told us that they are okay with a salary cut as long as they get their children to immunization. We have some recommendations that we think private sector can do to support children immunization, and this is based on our joint workshop with UNICEF and also with Ministry of Health. So the first one will be additional leave for mother or parents with children under 2. This is not a legal provision, but we see that this is something that can be an innovation for private sectors to do, which give flexibility for parents to take children to immunization. And what companies can do is identify clear and standard procedure to take this leave. They also need to provide this information through worker contracts or the socialization and also worker orientation. And the second one is support access to immunization services. So we see that when companies have working parents, then they can do some kind of needs assessment to understand how they can build strategies to provide better support. So they can collaborate with service providers. I have mentioned about community health centers, which are available across Indonesia. And it can be also immunization at workplace clinic, which will be much easier access for some parents. So they know that when the immunization is coming, or like they know that they have the certainty about the place. Or dedicated transport for immunization, especially for those working in remote locations such as the plantation. When we visited these places, and they said that it will be really help for the parents to take the children. And the last one will be the integrated immunization portal. We see that some of the challenges also relate to the provision of information for the parents. So we see that the private sector can identify key information to be made available. And we see that it can be around immunization schedule, it can be about immunization benefits and adverse events, as well as the type of vaccine by age. The private sector can also do the immunization focal points, like we have seen from previous presentation or from this morning discussion about the importance of communication, and this is something that can be done like among the workers to share information. And the last one will be, providing information from different channels, including from orientation break rooms or in the lactation rooms. So that's it from me. Thank you so much.
Thank you, Frisca. Our next presenter is Devi Leena Bose. Devi Leena is an expert on social change and behavior change communication, and she heads the social and behavior change communication at Kantar Public for all of South Asia. Previous to this position, Devi Leena designed, advocated for, and oversaw the implementation of methods to increase community confidence in and ownership of public health programs and preventative research. Devi's interdisciplinary training in human-centered design, participatory research, and public policy has given her a deep understanding of the complexities of human behavior and the importance of community engagement in designing and implementing effective SBCC interventions. Her research today is on a program to promote collective efficacy of couples in several important areas, including immunization, with a special focus on digital delivery. Welcome, Devi Leena, please.
Good morning, everyone. Thank you for providing me this opportunity to speak on this very interesting topic at this very interesting platform. I'm going to present today a work that we have been doing since 2018, and definitely summarizing 6 years of work in the next 10 minutes would be a bit of a challenge. So just a heads up, in case there are parts that you are interested in, I'm always available later after the conference. I would also like to thank all the partners who have supported this program, our sponsors, Gavi Unilever and Unilever Lifebuoy. And also the program was implemented and conceived by Group M. Kantar Public provided the research support. In my home country, India, we lose a child every 2 minutes to pneumonia and diarrhea. And as we heard today morning, these are preventable diseases. Vaccine exists, cost-effective solutions like hand-washing soap with soap exist. However, uptake of these very simple solutions remains a challenge. And with this in mind, we wanted to sort of see that, we know that public health is a shared responsibility. We've been hearing about it since the morning. The idea for this program was, how do we leverage behavioral research to better engage communities in the solution? The core idea of the program was the fact that every parent wants their child to be successful and lead a better life than them. Now, when we integrate the twin behaviors of immunization and hand washing with soap with parenting goals or successful parenting, we actually move the discourse from survival to success for the parents. The program, like I said, started in 2018 and has undergone 3 phases since then. It has reached over 3.7 million people. Today's presentation will focus on the formative research, which is phase 0, insights on what were the behavioral barriers, what kind of communication interventions were designed, and also touch upon some of the insights on the phase 3, which is the model testing phase, where we tested out different delivery mechanisms. So coming to the formative research stage, we used a mixed method study. This was done in the northern state of Uttar Pradesh. And we used both qualitative and quantitative techniques to understand what were the behavioral barriers. We leveraged on shadowing and participatory techniques like a day in life, projective card techniques to understand the intent-action gap. And what were the key insights here? In terms of immunization, one of the key barriers that we found was forgetfulness. People were so caught in the routineness of their life and mitigating day-to-day challenges that vaccination was not considered primarily as a parent's responsibility, but the responsibility of the frontline worker. Secondly, in terms of hand washing, there was it was believed that if the hands look clean and there are no visual signs of germs, then the hand is clean and you don't need to wash your hands with soap. In addition to that, in terms of successful parenting, again, the challenge was that it was, again, the financial stability and education was considered something that would bring in the financial stability. And health was definitely something where a long-term thinking was missing, and it was in a short-term structure that people were thinking about it. And of course, childcare definitely was something which was primary responsibility of the women. To address these, some of the programs that we launched used a 360-degree multimedia approach, wherein at the core of the program were facilitator duos who were peers of the parents talking about shared parenting responsibility, leveraging different SBCC tools and techniques. They leveraged on community mobilization through district launch and village launch. They leveraged the use of engaging platforms like gamified learning solutions through IPC sessions with the parent groups. Also, various mass media communication channels like mobile phones and film screenings were leveraged. And in addition to that, capacity building of the frontline workers as well as teachers were undertaken to support outreach through schools as well as Anganwadi centers. Additionally, we realized that local advocacy was very important to bring in the local leadership and get that buy-in from local leadership. So local advocacy efforts were also undertaken. Now, what were the key lessons that we learned in terms of insights on design? And we've heard a lot about some of these in the morning plenary session today. One of the important things that were working in terms of design was the fact that audiences have segmented needs. They're not homogeneous, and it was important to place their needs within the behavioral continuum. It was important to understand their needs from not just a knowledge perspective, but also in terms of habit formation, setting goals, ensuring social reward, and where their needs fell within the continuum. It was also equally important to strategize from the user's behavior resistance point of view, leverage social proof, leverage the existing social capital, and mobilize local influencers to help address some of the points where the end users might find resistance. It was also extremely important, and I know we've heard this, we constantly talk about not having a top-down approach, having a very engaging approach, but leveraging some of the tools like gamification, like gamified learning, dialogue-based interventions to support informed decision-making partnership was something that was definitely a key design insight for us. Additionally, it was very important to have the openness to iterate and also have mechanisms of formal or informal research to keep your ears to the ground and keep learning from the insights that are coming from the ground. Dr. Matua in the morning emphasized a lot on storytelling, and that definitely was something that came up as one of the insights on design in our research as well. Use of compelling narratives, use of positive deviant stories were some of the tools that were definitely working. Another key important lesson was that a lot of focus usually is on being positive, being optimistic, but it was equally important, while positive message framing helps, address the issues that communities are facing. The message has to resonate with what their emotions are and address it in a manner and tonality that it resonates with the community. Complex behaviors demand simple actions, and it was important for us to break these complicated knowledge into simple, practical solutions. So for example, one simple solution of breaking them up, setting the goal and saying that, okay, in 5 years, 7 times you need the child to vaccinate, help set the goal and built in a reminder for the parents that it was a simple message given, you need to vaccinate your child 5 times in 7 years, and that resonated with the community. And lastly, what was very important for us to keep an eye on was that whatever we were promoting as behavioral interventions were definitely supported by the system, and it wasn't, that the systems that they were interacting with were not able to support these programs. Having done that, having understood what were the ways in which communication design could be done, the second critical question was, how do we deliver these? What channels or combinations of channels would work? And with that intent, we came to phase 3, which was the model testing phase, where a quasi-experimental cross-sectional survey design was used, and we surveyed more than 13,000 parents across 5 different monitoring rounds in 5 districts of Uttar Pradesh. The 3 models being tested were digital model, which included a voice and video out model. Parents were enrolled into the program through an IVRS-based system, wherein people could give a missed call to a registered number. There was also promotional activities which were done, and weekly messages these were personalized reminders sent to parents. The second model being tested was a self-help group model, where we leveraged the existing social capital, existing community groups, provided them training, and then used the cascading effect of these SHGs, as well as community service providers to cascade the information further at the community level. The model leveraged on community conversations. The lastly, FLW model was used, wherein the capacity building of frontline workers was done to aid them in communicating about some of these behaviors in a much more interactive and easy manner during both household visits as well as during community conversations. The models were in terms of evaluation, they were evaluated across 3 areas: shift in knowledge, shift in perception, and shift in practices. What was the change that we saw? We saw that all the models definitely were successful in shifting the knowledge needle. There were positive shifts across all the models. However, the digital models definitely were way more successful than the SHG as well as the FLW model. And this was because the digital models' outreach was much more targeted, and there was a more direct interaction through the digital models. However, when it came to shift in perceptions, what we saw was that the SHG model improved behaviors with regards to tracking, and digital model wasn't that successful. And one of the reasons for this probably was the fact that SHG model could leverage on social accountability, which is one of the key behavioral driver changes. While we also saw that digital model definitely was way more successful in addressing forgetful-related barriers. So we saw digital model could reduce forgetfulness of critical occasions of hand washing by almost 16 percentage points. Lastly, in terms of practice, again, we saw that the digital models definitely were way higher in terms of their ability to increase the practices. We saw that rotavirus vaccine uptake increased by almost 36 percentage points, and so was the pentavalent vaccine uptake. In aspects of hand washing also, we saw similar trends mostly. Now, what was the insights that come from this on what kind of models do we work and not work? And usually our focus has been on, when we are designing interventions, try and understand what different communication channels to communities have access to. But the study also highlighted the fact that while we frequently focus on media accessibility, it is equally important to focus and determine if the medium matches the required behavioral adjustment. For example, when it came to social support and reviewing outcome objectives, we saw that it was the SHG-based IPC model and community conversations that definitely solved the purpose and were more effective than digital strategies. However, when it came to aspects of shaping knowledge or goal setting, digital interventions could be better leveraged. The second learning for us was diverse needs demand diverse media. And communication requirements vary much like behavioral needs. And every medium has its own strength and limitation. Blended approaches definitely can help us maximize reach and re-emphasize and reinforce the message in a way that appeals to the learning styles of the end user communities. It is in best interest of the program to actually capitalize on strengths of these different learning channels and also compensate for limitation of each of the medium. In our understanding, what we realized was that small discussion groups are conducive to clarification, discussion, and deliberation of issues towards change, while digital support not only support outreach, personalized messaging, catering to segmented end user needs can also surmount certain behavioral barriers like forgetfulness. Lastly, what is very important, and aspects of this again were touched upon in the plenary today, is to think when you're thinking of selecting your communication channels, what is the power and gender dynamics? It is very important to actually understand who has actual control or decision-making over the channel. We all know that there is a gender divide within the digital divide. Women's access to phone and other communication platforms are heavily gendered. It is equally important to understand if the chosen routes are able to break away from the power structures. For example, while our survey showed that if the frontline workers are one of the most reliable sources of knowledge, but experiences from the ground also highlighted that the information power that many of the frontline workers have often act as an hindrance for open discussion because communities feel judged and obligated to say the right thing and do the right thing. With that, I would like to end my presentation. And if you have, and we do we have 2 minutes to play a short film? No? Okay. So with that, I would like to end my presentation. And if you have any questions, you can always reach out to me. Thank you.
Thank you for that, Devi. And our final speaker today is Dr. Emily Hoffman. She was born and raised in New York, graduated from the State University of New York Downstate College of Medicine, did her internal medicine residency at Montefiore Medical Center, and stayed an additional year as a chief resident. Dr. Hoffman is passionate about community health education as well as medical education, and she was part of medical education pathway in both medical school and residency. She's now finishing her second year as an infectious disease fellow at the New York University's Grossman School of Medicine and will be staying on as a clinical assistant professor. And Dr. Hoffman's research today focuses on peer education for routine immunization among parents with mistrust of the medical system in New York. Welcome, Dr. Hoffman.
Thank you so much for that introduction. Good morning, everybody. Today I'm going to be discussing developing peer vaccine educators within community healthcare practices, a pragmatic multi-site randomized controlled trial of peer education to increase routine pediatric vaccine uptake in New York. So we've heard multiple times this morning about how effective localized strategies are urgently needed to improve vaccine acceptance among hesitant communities. Peer health education, where members of a certain at-risk group encourage others to adopt health-promoting behaviors, has demonstrated consistent effects regarding health behavior change, but has not yet been studied related to promoting vaccine acceptance. Now, peers may be more likely to influence behaviors of fellow group members because they facilitate a certain level of trust and allow for more open discussions. And this may be particularly useful for groups who have mistrust of healthcare authorities. Which brings us to our study population today, which are Haredi Orthodox Jewish communities. And historically, there has been tension between this community and state public health officials, with mistrust in public health authorities. And to give everybody a little bit of a glimpse into this specific group, Haredi Orthodox Jews comprise socio-religious subgroups within Orthodox Judaism. They maintain strict adherence to Jewish law and tradition. They have limited engagement with secular culture, and they often live in close-knit insular communities. And notably, they have been specifically targeted by anti-vaccination establishment with disinformation. And so unfortunately, because this community has suffered from under-vaccination, there have been significant vaccine-preventable disease outbreaks that have occurred in this community over the past decade. Notably, there was a mumps outbreak in 2009-2010, a measles outbreak in 2018-2019, and most recently, a case of vaccine-derived polio that occurred in Rockland County, New York last summer. So Dr. Ellie Carmody, who is the PI of the study I'm going to be talking about today, has done some prior work with this community. And back in 2021, she published Knowledge and Attitudes Towards COVID-19 and Vaccines among the New York Haredi Orthodox Jewish community. And a few things to note from this work are that the COVID-19 pandemic changed people's perceptions of vaccines and lowered pediatric vaccine confidence. Additionally, most participants reported trusting their local physicians and looking to them for medical information, as opposed to public health authorities. And this is not just unique to this community, but we've all been talking today about how there's decreasing vaccine acceptance in the United States and globally. And I wanted to highlight this systematic review that was just published in May of 2023 in the Journal of Vaccines. And I noted below, a key point that I wanted to highlight from this review, where they say the key to effective messaging was identifying vaccine sources and/or messengers that are perceived to be trustworthy. Yet physicians, as trusted messengers, found it challenging to convey vaccine information to those with strongly held views or who were resistant to further information. And so, given known under-vaccination in these Haredi Jewish communities and falling vaccine rates largely due to erosion of trust, we felt that it was important to take a fresh approach to vaccine acceptance and change not just the message, but the messenger to be someone from within, someone who would be knowledgeable about vaccines, but also knowledgeable about the community and their values, and to have them co-located in a place where people in general go for medical information. Which brings us to our study design, which was to conduct a multi-site, unblinded, randomized control trial evaluating the effect of peer-led vaccine education on acceptance of pneumococcal conjugate, PCV13 vaccination among eligible Haredi Orthodox Jewish parent-child pairs. So parents of children up to 18 months overdue for routine pneumococcal vaccination were randomized to either routine care alone or a peer educational intervention in addition to routine care. And this was done at 3 different study sites at pediatric practices in Brooklyn, New York. So our inclusion criteria, you had to be a parent of a child up to 18 months, born at greater than or equal to 35 weeks gestation, eligible for a dose of PCV13. You also had to self-identify as Orthodox Jewish and be able to provide informed consent. Our exclusion criteria included being unable to communicate verbally in English or Yiddish and being unable to utilize a Yiddish interpreter. You were also excluded if you had already participated in this study or if you had an appointment that day in clinic to specifically get vaccines. A little bit more about our study procedures. So our Haredi peer educators were trained in motivational interviewing and pneumococcal vaccine science, and they had to pass a written exam to ensure competency. Peer educators provided semi-scripted verbal counseling with a written handout at enrollment and follow-up telephone engagement at day 30 and day 60 with those in the intervention group. And then all study participants were contacted at day 90 for outcome assessment, and vaccination information was verified throughout the study through a municipal immunization registry and or through clinic records. And then additionally, the parental attitudes about childhood vaccines, known as the PACV survey, was conducted at enrollment and a 90-day follow-up. So as I mentioned on the slide before, the discussions between the educators and the participants were semi-scripted, but there were certain key core messages that we wanted the educators to deliver over the course of that discussion. And these key messages focused on talking about aspects of pneumococcal disease and then also talking about safety and efficacy of PCV13. And I highlighted in those bullet points a few of the core messages that were delivered. And then you can see on the right is the written handout that we also provided to all the participants. So this is just kind of an overview running you through the study schematic. Basically, you can see on top, day 1, obtaining informed consent, screening individuals, obtaining demographics, and then everybody in the study completed a baseline PACV survey. They were then randomized to either the educator group or the routine care group. And then for those in the educator group, they received follow-up telephone or text engagement with the educator at day 30 and day 60. And then everybody in the study was contacted at day 90 and completed the same PACV survey again at that day 90 mark. So our outcome measures, primary outcomes, child's pneumococcal immunization status by allocation arm expressed as at least 1 dose received within the 90-day interval following randomization. Secondary outcome, differences in mean scores by allocation arm on questions in the PACV survey done at enrollment and at 90-day follow-up. And statistical analysis was performed via STATA using t-test logistic regression and Mann-Whitney. So here are our results. So with an N of 147, a look at our participants' demographics. So 98.6% of our participants were female. The average parental age was 27.8 years. The average child age was 8.5 months, and you can see on the right a breakdown of all the children's age for everybody in the study. 70% of children had received no prior doses of PCV13 at enrollment, and 94% were greater than 2 months old. And notably, there were no significant differences between groups' demographic composition or their baseline PACV scores. So I wanted to just run through a few key points from the baseline survey results of this population, just to give you a little flavor of this population in general related to vaccines. So one of the survey questions is, have you ever delayed having your child get a shot for reasons other than illness or allergy? And you can see here it's split about 50-50, that about half have said, yes, I have delayed giving my child a shot, about half said no. And then the second question, have you ever decided not to have your child get a shot for reasons other than illness or allergy? And you can see here, it's a much smaller percentage in yellow that have said that, yes, I've decided not to give my child a shot. And I wanted to show this just because, in general, this population, most of them are not completely anti-vax, where I don't want my child to get a shot. Most of them just delay giving their immunizations. Another look at one of the survey points, so related to number of vaccines, one of the survey prompts says children get more shots that are good for them, and participants have to either agree or disagree. So you can see here that a majority of people in this population agree that children get more shots than are good for them, or they're at least neutral to that statement. And then looking at vaccination timing, one of the statements is it is better for children to get fewer vaccines at the same time. And you can see down below about 15% strongly agree, 64% agree. And so again, a majority of this population feels it's better for children to get fewer vaccines at the same time. So now let's look at results related to our outcomes. So related to vaccine uptake, at day 90, participants in the peer education group were significantly more likely to have received at least 1 vaccine dose during the study period, 29% versus 13%, with an odds ratio of 2.75 and a p-value of 0.022. We also looked at vaccine uptake by child age, and we saw that at day 90, participants with children less than 1 year old in the peer education group were significantly more likely to have received at least one vaccine dose during the study period compared to those in the routine care group, 37% versus 13%, with an odds ratio of 3.9 and a p-value of 0.007. So now looking at vaccine confidence. So at day 90, participants in the peer education group had lower mean total PACV scores compared to the routine care group, reflecting greater confidence in vaccines and higher perception of safety and efficacy, with a p-value of 0.033. We also saw that at day 90, participants in the peer education group had significantly lower mean scores on individual items in the PACV compared to the routine care group. And those 4 individual items are listed down below, as you can see. And I wanted to highlight one particular survey question that was found to be significant, more so in those in the peer education group. So you can see here at day 90, when asked again, if you had another infant today, would you want him or her to get all the recommended shots? You can see above that the routine care group, about 50% said, okay, yeah, if I have another infant today, I would want him to get all the shots. About 22% didn't know, and about 29% said, no, I wouldn't. Whereas in the peer education group, you can see a 10 percentage point difference between the routine care group and the peer education group, related to them saying, yes, I would want, 59% said I would want another infant to get all the recommended shots. And you can see much, much less said no. So we felt that overall this was a very positive finding related to the peer education. And I just wanted to highlight a few study challenges and limitations. So not all participants received the full peer education intervention if they were not reachable at day 30 or day 60 via telephone. Also, the final PACV survey was conducted with the research team over the phone, which could have impacted responses and results. And then lastly, results may not be generalizable across all different study populations and groups, or for certain other vaccines. So in conclusion, we found that peer vaccine education appears to be effective in increasing vaccine acceptance and confidence compared to routine care alone, and may be particularly valuable in decreasing vaccination delays for younger infants. And I'd like to thank our study participants, our entire study team, and especially the PI and mentor of this project, Dr. Ellie Carmody, who is here in attendance with us today. Thank you.
Well, thank you very much to all of you for those very exciting presentations. I don't know if we have Dumi on Zoom or not, but if we do have Dumi on Zoom, please include her. And we have mics in the audience and going around. So if you do have questions, please come to a mic or put up your hand. I think somebody will bring one to you. But I thought I might start out with a question for Frisca while you're getting your thoughts together as well. And so I as a combination of a clarification and a question. So in the industries, the private sector that you studied, is there already support and parental leave and policies when children are already sick, or when the workers themselves are sick? Is it the kind of case where it's just like those policies haven't made their way into preventative care and immunization? Or is it actually that there's actually no support, right? And it's difficult whether your child is sick or needs immunization. And immunization might be a good lead-in, given the tragedy of children dying without immunizations, right? That's kind of something that employers can latch onto when we try to talk to them about why support immunization when they're maybe not supporting other things. So I just kind of would like to hear your thoughts on kind of the strategic use of this within your context.
You should be working. Yeah. So thank you. So with the working parents, one of the findings that we heard from many parents, in some workplaces, yes, they do have that leave when the children are sick, or if the working parents themselves are sick. but it is not very common, unfortunately. Well, likely because like, yeah, there are like many informal, I mean like this is like a labor intensive, which continuously like will need workers to be there and do the work. But then like, yeah, there are like some places that do that. So if workers need to take time off for their children, they usually will just use the leave that they have. I mean like as in like annual leave. But then like, yeah, for the immunization itself, there is no specific leave for at the time being. So yeah, either parents will take that annual leave, maybe it also depends on the supervisor. And yeah, this is something that we see can be more structured or more integrated in a better way among workplaces to make sure that people have the access, the flexibility, rather than barriers that they need to think twice, or even more like what is the cost of taking the time off or even leave, especially for mothers. And we see that one of the potential that can be done, even though yeah, this is obviously still in discussion, about adding the additional leave to the parental leave or the maternal leave. So in Indonesia currently we have 3 months leave for mothers who just gave birth. And we think that, yeah, just like I mentioned earlier, it can be additional leave. For example, say there are like maybe like 5 more days leave that can be added for the next 2 years that parents can take flexibly, so they can take their children as needed during the first 2 years of their children to make sure that they get the full routine immunization.
Very interesting. And it also, I mean, it's interesting to me because it also sounds like there could be an opportunity to kind of reframe sick leave as sick and preventative health leave, and then we would all think of it very differently. Okay, so great. We have a line already to ask you questions. Before you ask a question, would you please identify yourself, your name, where you're working, what country you're from?
Thank you. So I'm directing a question to Dr. Hoffman. I'm Associate Professor Holly Seal. I'm from the School of Population Health at the University of New South Wales, and I'm part of a Vaccine Champions program that's been running with colleagues who are standing behind me. And so very much interested, obviously, in the program that you ran. And I've got 2 shortish questions. The first was, I wondered whether you could just elaborate a little bit more on kind of the training that you provided to your peer educators. And also I was interested in why you didn't have an outcome focused on your peer educators in terms of changes in their confidence, their capacity, their motivation to then actually, do the outreach into these communities, whereas you focus all your outcomes on the parents themselves. So thank you.
Okay, just making sure this works. Thank you so much for your questions. So, sorry, can you repeat your first one?
So
I have the second one in my head.
Just what training did you provide your peer educators?
So we basically made an entire Google Doc folder full of resources for our educators to go through. This included, like I mentioned, articles and papers to read just on motivational interviewing itself, but also specifically, like I said, on pneumococcal vaccine science. So we gave them information about pneumococcal disease so that they can understand, specifically that bacteria, what we're trying to prevent, et cetera. And then also information about the PCV13 in and of itself. What is the conjugate vaccine? How does it work? Our risks, benefits, all those things. So they went through all that information, and all the educators went through that same folder of information. And then again, we developed a written exam, essentially, that they all had to go through so that we can ensure that they actually understood the material and can deliver that well. Plus, we, all of us on the study team, interviewed these people, have had multiple discussions with them, just even interpersonally kind of talking about vaccines, and felt that we had really vetted these people before they started. And then related to, looking at outcomes, and I think what you're getting at is, did we look at the educators themselves to see how they did in the discussions, or kind of speak to them more about, how this all went? So we did have a discussion about having a forum, for example, on the peer educator feedback and seeing how participants felt about the educator. Did they feel like the educator cared about their child and was looking out for the child's best interest? Did they feel like they weren't being judged in the conversation, things like that. And ultimately what happened was, we kind of felt like we wanted the study to get going a little bit before we started doing that feedback. And then the other issue we kind of really ran into, which prevented us from actually getting that feedback, was that there was just so much paperwork and things that people had to fill out at clinic on that day of enrollment, that really after the session with the educator, it was just too hard to get people to fill out another form. And we couldn't really do it at follow-up because the peer educators were calling at day 30 and 60. So it was kind of like, okay, here, evaluate me. And it was kind of like, you're not going to evaluate the educator when you're on the phone with the educator. So I think going forward, if, this is done again, every clinic or however people are getting vaccinated in different areas, different countries, it has to be weaved into the workflow in the initial study design, and we kind of came across that challenge, but I agree. It's definitely something we wanted to do. Yeah.
Thank you. Professor Margie Danchin from the Murdoch Children's Research Institute in Australia. So Dr. Hoffman, I also wanted to expand. We're going to be presenting on our Vaccine Champions program on Wednesday, so be keen to see what you think about the differences. But what we found, we ran a 1.5 day training program for both healthcare workers and community advocates, and we included both the what and the how. So the what is really important in terms of the specific knowledge about vaccines, whether it's COVID or routine vaccines, critical, but actually what was more important was the how. So you did motivational interviewing, but it sounds like they read a manual or something. We found that role plays, actually practicing how to have an effective vaccine conversation multiple times over and over, getting them to do it in groups, in pairs of 2s and 3s, modelling the conversations on a stage in front of everyone. That is where the true learning took place and still needed more reinforcement over the 1.5 days. So I'm just keen, and I wonder if you might, did you do any role plays or actually vaccine communication training, or was it just the reading about MI in the book?
Yeah, so we didn't do, yeah.
Right, okay. Because I think that's really, really critical in terms of actually changing behaviour. And I agree with Holly, actually measuring the outcomes for, the actual peer educators is critical. But Dr. Omobowale, is that how you pronounce your name? I also wanted to ask you similarly for your social influencers. What training did you give them? Because again, we've run a similar program in Vietnam, and addressing rumours and misinformation for the community, for our community advocates, so that was faith leaders, community leaders, again, needed a lot of training to help them to know how to address those, conspiracy theories and rumours and myths. And so what training did you give your influencers?
Okay, the influencers were actually not really formally trained, but we had what we called one-on-one discourse with them over a week. We just go to them in their shops, those we have identified to be influencers, and we strike conversations about vaccine, about the misinformation, and we listen to them. Then we tell them our own side of the story. Then a kind of conversation to reach an agreement. And in case of where they have wrong knowledge or information, we tend to tell them what is right. And we go back to also continue the conversation over a week with each of them. And that was where we were sure that, okay, we could actually activate this approach to help us with the mobile clinic.
And by the way, I loved your model. I thought it was brilliant.
Thank you.
And down. Hi, I'm Associate Professor Katie Atwell, and I lead VaxPol Lab at the University of Western Australia. I'd like to thank all of the speakers for amazing talks. Thank you. My question is actually for Frisca as well. So I just consult my notes because it's a little bit complicated. I was really interested in the idea that you're trying to engage with the private sector to pursue the vaccination of the mums, particularly in informal and labour-intensive sectors. And I have to admit to being a little bit cynical about their wanting to get on board with this just as a matter of goodwill. So I was a little unclear about the goals of the engagement, and is it about actually trying to change government policy? And with that in mind, I was curious about whether the 5 days leave that you spoke about as perhaps a policy goal, is that unpaid leave or is it paid leave? So number one is about is it about trying to actually change what government does? Or if it is about actually trying to get business on board, then again, you described engaging with UNICEF and the Ministry of Health, but have you engaged with employer groups? And have you kind of understood what their drivers would be? And it strikes me that, again, building on that idea of preventative health, surely it would actually be about productivity and absenteeism in the workers and trying to prevent that in the future. So I was just interested if you could embellish those ideas a little bit more, please.
Thank you for the question. So this is actually something that is still going as well. This is a study that we did back in 2021 until early 2022. And these are like some the recommendations. These are actually the one that I presented are just like part of the recommendations. So we have separate recommendations actually for the government and also for the private sector. The idea, like the bigger picture, is actually part of the UNICEF work. There is like a UNICEF Indonesia representation as well in this room. But part of the bigger work is actually about advocating family-friendly policy to the private companies. And one of the component of that is actually to support a better immunization for the children. So for the government, yes, like part of the policy, we want to see how the government can also see this evidence and then like try to make a more like an enabling environment for, or incentive, if you like for the private sectors to also support this. So I mentioned earlier about, for example, collaboration with the health service providers. We are thinking maybe like this is something that is, that we recommend and still in the discussion, whether if the government, for example, because the government organized the community health centers, if there is a standardized procedure or maybe how the private companies can tap into the community health centers to provide the information or maybe the immunization service itself, then hopefully it will be easier for companies to see, it is probably minimum cost for them, like to tap into the service, but then can also support a better coverage for the working parents. So it's, thank you for that question. And yeah, I do agree that it needs like different stakeholders to chip in into the process of supporting the children immunization. Thank you.
Thank you so much for all great presentations. I have a few questions, but I'll just only pick up one. My name is Ridwan. I work in UNICEF East and Asia Pacific Regional Office. One of the works I do is looking after digital health. I'm supporting countries on investment of digital health technology to provide solution, including in demand issue. So I'm really happy that you are presenting some of the finding from the digital health channel. One thing I want to ask is, did you do a more in-depth analysis on those 3 different channels into different groups? For example, the socioeconomic groups or age groups, or maybe different type of people. Which one is better? Which channel is better for those groups? And then, do you have more insight on then if we invest into the reminders or using the digital technology, what other advice you need to take in to the consideration to make sure that it is impactful to address the barriers of vaccination from the demand side? Thank you.
Thank you so much for those questions. I think while I say these, I think also important to acknowledge that a lot of digital engagement related work is still, ongoing, and it's still at a very naive stage in some ways. It's still at a nascent stage. We did do parts of what you were mentioning. So we had an intervention and control group to begin with. And within that, based on the demographies, different, the interventions were firstly done in different districts with different demographies. We do have certain classification based on income-based classification. In India, we have a caste-based classification. So those classifications do exist. However, we didn't see much difference because the districts that were chosen and the kind of communities with whom the intervention happened, I wouldn't say they were homogeneous, but more or less from the similar structures, right? So we didn't see much difference because one of the questions or the hypothesis which we wanted to also test out was that these interventions might work differently across different classifications as we traditionally see. But having said that, I think there is more research that needs to be done because this research probably wasn't able to capture those because the interventions were targeted around certain classes, and already there was an audience segmentation that was done when the interventions were designed. To your second question in terms of what role do reminders play and if we saw that has a difference, that was again something that we wanted to take up as a question, but it was, like I said, it's 6 years of work and it was an iterative process, both in terms of design and the research design as well. So by the time our third phase concurrent monitoring was over, that's when we were seeing these issues and questions coming up, and definitely something that, because we are now doing a pilot of this in other countries as well. So in the next scale-up stage is where we would like to get some of these questions also integrated. But definitely in terms of certain behaviors where the segmentation was done based on behavior, where reminders could play a critical role, there we saw that shift happening. So for example, in terms of practices with regards to immunization, hand washing with soap, digital reminders did work wonders. There was no way to cross-collaborate whether it was that digital reminder that worked or not. And that's a challenge of evaluating behavior change communication programs. Thank you. Yeah.
Yeah, so I just wanted to answer the question on digital reminders. So we did observe that digital reminders definitely play a great role. So in India, what also happens is that we have a community structure. We have frontline health workers who generally reach out to the parents and invite them for the vaccination session, the outreach vaccination post that happens in the session that happens in the community. But then due to community structures or the availability of parents at home, there are issues when these frontline health workers are not able to reach out to the parents and invite them on that particular day for immunization. So immunization reminders that we use in the program were actually designed in a way that it reached out to the audience 2 days prior to the immunization day, 1 day prior to the actual immunization day. So then they were getting that information at the comfort of their home, wherever they were, because it was sent to the digital phones. So they were aware that, okay, their child needs to be vaccinated and the vaccination will happen on such and such day at such and such place. So that definitely helped in mobilizing the parents and getting them to the immunization session and finally to the immunization. Yeah, thank you.
Hello, everyone. This is Dr. Navneet Bicha. I'm from Nepal, and I'm a WHO TDR fellow at Indian Institute of Health Management Research. My question is to the speaker from Malawi, that what were the barriers in community engagement for this RTS malaria vaccine, and how can this vaccine help in integration, and how can this vaccine help in the re-establishment and revival of the routine immunization program? Because we see that this vaccine has been given below 2 years, and how will this introduction of new vaccine help in identifying the barriers and driving vaccination and re-establishing the routine immunization? Thank you.
Thank you for that question. For Malawi, what struck most from this study was that the major barrier would be because of the COVID-19 vaccine that has just passed, which carried a lot of hesitancy within the region, and because the people are not so trustworthy of the current healthcare system, so it's harder to reach out to the communities and explain about introducing a new vaccine to the children, on top of having multiple vaccine campaigns that have been happening, such as the measles vaccinations and polio. So there's really need for a proper community engagement and proper advocacy for the vaccines. And this boils down to proper training of the healthcare workers, as well as proper planning for community engagement within the region. And the introduction of the malaria vaccine would be more beneficial in the routine immunization care, because this disease is already of a high burden, and the community is most likely to be more acceptant of the malaria vaccine compared to the other vaccines. Because if we reach out to people and ask them which particular vaccine would they need within the routine vaccinations in Malawi, I think malaria would be the very first option for people, rather than the other diseases, because people have really experienced the deadliness of the disease. So introducing the malaria vaccine would really positively impact the routine immunization in Malawi. Thank you.
Thanks everyone for an excellent presentation, very thought-provoking. My first question is to Frisca. Very brief questions. Workplace health promotion, is it something that has come through strongly, either in Indonesia or any other countries that you have looked when you're looking at the results and the discussions of your study? Workplace health promotion. Yeah.
Oh, what's the work health promotion?
No, not what it is. Have you come across that being used either in Indonesia or in any other countries with respect to vaccination?
So promotion related to vaccination at workplace.
At workplace.
At workplace. So in some of the workplaces that, this is from the working parents that we met. So they say in the lactation room, they have the posters or some information about the vaccination that parents need to do for their children. But yeah, it is still it is not very common. It's usually the bigger companies or maybe those who have international have to comply with international standards. They will be the one that will are more likely to comply with not comply. To provide those kind of information. But the promotion that we find more strongly is actually at the community level. So it's from the health service providers, the volunteers who are in the community, and it's usually easier. They have WhatsApp groups with the working parents and stuff. But in terms of workplace, what we found in the study, there are some, but it's not common yet.
Thank you. A common question to all the presenters. In your work, have you come across traditional health practitioners being used as a voice or change agents for vaccination? First one. And second one, there's a lot of work going around in the area of responsive dialogues, which is being used by the Wellcome Trust, especially for antimicrobial resistance. Now, AMR, vaccine preventable diseases, we are all interconnected. We can't work in silos. So have any one of you used or have the experience of using responsive dialogues working with the communities? Thank you.
Okay. TBA is being used as agents of exchange for health issues. Yes, in Nigeria, they have come across a couple of them, not on the study, but on other studies, and have some kind of interaction with them. And responsive dialogue, it's important. And the group of people I work with, I think it's like a tool you just have to adopt every time if you really want the results.
can take this. So even in our initial formative research, one of the findings was that people were, while there was a huge dependence on frontline workers to get the vaccination done, for other health issues, people were dependent on the quarks or the unofficial traditional systems, right? And I think that's definitely an opportunity to be leveraged, and a lot of effort needs to go in understanding what the gaps there are and how can they be better integrated within the broader system. And it is debatable. I do know that there is the right and the wrong side, but I don't think that our research at this point of time went into that direction. But there is scope, and it's a much larger debate as well. With regards to responsive dialogues, again, I think the fact that there were these community conversations being led by peers within the community, and it was not within the framework of, we will talk about health today. The self-help groups were meeting in general, and health was one of the things that was induced within the broader framework, was aspects of the responsive dialogues, but definitely community conversations, and we have done this in multiple other domain areas, are in the true sense a very strong change agents in some ways. So definitely something which needs to be further explored. And I would say harness the potential of those kind of tools.
Thank you so much. I forgot to introduce myself. I'm Sunita Srinivas, representing two different organizations. One is 3 Analytics, where we are in the private sector, working in people-centered digitalization for vaccination was one of the things. Also, I come from Rhodes University. I used to be there as a professor and continue to work in community-centered research projects. So that's why that interest in what I asked. Thank you so much. Much appreciated.
Great.
All the
Thank you
best.
for the questions. So we have about 2.5 minutes left. I'm sorry we won't get through all of you, but maybe we can get through 1 or 2.
Okay.
We'll get to yours. Go.
Okay, great. Yeah, I think I'm lucky. Yeah, thanks so much. I'm Sonny Ibenemi. I'm from Nigeria, but I work here in UNICEF Airpro, the regional office, and Ridwan is my supervisor. And of course, I'd had 2 questions. I had asked one. I work as a digital health specialist, so the question on digital health, he has asked that. Thank you, Ridwan, for that. For the second one is to my sister, Dr. Omobowale. I'm from Nigeria. So please, I think it's a good time to discuss issues of Nigeria here. You had a very good, excellent presentation. I love your research. The border market you referenced, I've been to Ibadan, and I've shopped in that market. It was a very good platform to do such a research. But my question is around implementation research. From your study, to what extent does academia get involved in influencing policy in Nigeria? How does research translate to action, to practice on ground? Because in Nigeria, I've had several experiences, mothers from the market coming to me, asking me for money for them to be able to get their children immunized, and it's beat my heart. Some ranging from 15,000 naira to 17. I mean, a lot of money. And I was like, why all this? Why won't the government do something? And of course, we've had excellent research. How can, the academia, to what extent do you lend your voice to change the narrative in Nigeria around, the political platform, the governmental system to adopt some of these and try to change those narratives to grant access to these children regarding the vaccinations? Thank you.
Okay, thank you, Sonny, for the question. Let me quickly say that when it comes to the market study, I've been doing this since 2009, and I'm passionate about it because in Nigeria, a lot of children, many children are raised even on the market space, and the market space is equally a public space where a lot of health, information about child health flies around, both good and bad, and misinformation, missocialization. And I'm also passionate about the study because I'm also a product of the market. I had my childhood and teenagehood also in the market, so I'm partly raised in the market, and I sit to the everyday taking for granted social realities of immunization. But when we started this study, we partnered with the local government. And I must tell you that one of the things we actually faced was that some of the local government chairmen told us, and I'm going to say it as plain as it is, that, oh, you people from university, you are here. We don't have money, oh. And we had to explain, yes, we don't have money, but we need your support about this, and this is what we have for you. And I can tell you, in public health, especially University of Ibadan, we have a lot of people who are involved in the different studies, the Ajuwons, the Omibodunus, the Olaleyes of blessed memory, and we are trained on a daily basis to engage the government. During the COVID-19 pandemic, I was involved as volunteers to government or your state government group that's worked on the social behavioral issues, and some of the recommendations were taken. But I must tell you that it's a lot of work, and it takes perseverance and constant, you have to talk to them, and some of them will think that, oh, you have grant. And when you have to explain to them that, see, this funding is for the study, it's not for me to give to you or something. We need you to contribute your own quota. And I want to believe that if we keep doing that, a lot of academics are doing that, just like myself. And my institute, we are engaging the local government, where we know that the grassroots, people at the bottom who are vulnerable to this, and we want to see how far, because we started recommending some of the findings to them, and some of them have actually, adopted a bit part of it, but we are still seeing how, okay, maybe when we do this often, we talk about it, we put it out, and we talk to them in the language that we understand. That is very important. And like they said in the morning, understanding the structure is very important. So we're trying to do that, and I want to believe we get there. Thank you.
And I'm afraid with that, that will be our final question. We're out of time, and apologies for not getting to your question, but asking you to shift them over lunch with our panelists. If you could please seek them out and ask your questions, we'd appreciate that. Thanks again to everybody on the panel, including our digital panel. Thank you so much for joining us on Zoom, and we're so sorry we couldn't meet you in person. And I've been asked to remind everybody that it is now lunchtime, if you are wondering. And lunch will end sharply at 2 o'clock, so the next sessions will start sharply at 2 o'clock. And that session will be vaccinating across the life course, maximizing the benefits to all. So please enjoy your lunch and get promptly to your next sessions at 2 o'clock. Thank you, everyone. Thank you so much.